All right, the red light is on. We might as well make a start. Thank you for coming. Thank you especially to those of you who are here who went to the Biomed Ball last night. I'm guessing that the majority of people who went to the Biomed Ball are not in the room right now. Anyway, so I hope you're not nursing a too sore head at home when you're listening to this. So I apologise that the due date for the assignment was on the night of the Biomed Ball, so in future let me know in advance because we can take that into consideration when we do our timelines. But I found out yesterday it was too late then to make a change, so sorry about that. Most of you will have done the respiratory assignment now, and I hope you probably found that you were pulling your hair out because it was very challenging. It's quite difficult, but I hope you have some time over the next few weeks to reflect on all the things that you learnt by overcoming those challenges and difficulties. So what I'm going to do for the first half of this lecture, probably won't go for the full time, but we'll see. Knowing me, I'll fill up the time. Is we're going to have a look at the respiratory block, and we're going to start pulling it together so that it makes a bit of sense to you, very much like what Terry did with the metabolic syndrome block and what I did with the stem cell block. So that's been in response to suggestions that we've had through the Staff Student Liaison Committee and through SES that we have these sort of wrap-up lectures. On that note, I should let you know that we're actually meeting with your student representatives today at 1:30. So I would suggest if you have any suggestions for improvements, or if you want to let us know things that you really like, or things that you'd like to maybe see done in the next 3 weeks or 4 weeks before end of semester, let your student reps know by 1:30 today so that they can let us know. Anyway, that was a bit of a segue. So the second half, once we've pulled together the respiratory block, is going to be to introduce you to peer assessment. And that's going to be important because your final piece of continuing assessment for this subject is going to be evaluating the work of your peers. And you're going to be doing some self-evaluation as well through that process. So I'm going to let you know why we're doing that, and I'm going to let you know how we're going to do that as well, and to provide you with some information on how to approach it and where you can find help in doing that. So I trust you enjoyed the respiratory block of lectures. I think we've had some terrific lecturers from around the university and from hospitals as well. And I've put here the respiratory block of lectures as a reminder, but I've also included the final frontier, which is the pain management and drug dependence block, because you'll probably be thinking, how did Robin Room's lecture on alcohol connect with the respiratory block? And that's because there's actually Nathan Grill's lecture and Robin Room's lecture are actually going to be interwoven into the pain management and drug dependence block. So while they might discreetly not appear to be part of this block, I'd like you to start to think about the connections between and across them. And it was a fantastic lecture, or lectures from both of them. Substance use disorders we'll talk about in the next few weeks, and Mike McDonough talked to you about cannabis smoking, and we're actually going to have Jim Angus talking to us about pathways for the use of prescription or regulated cannabis for medicinal purposes around Australia, and his pathway navigating that. And Mike McDonough will have another video lecture as well where he's going to talk about drugs of dependence and also alcohol as well. So they are going to come together, and part of the final tutorial in week 12 is going to be to make those connections and to pull all the content together. So what I'm going to do now is to have a look at the learning objectives for each of our lecturers. And there is some overlap because Daniel Steinfurt, through the video recording, gave you a really nice broad introduction to clinical aspects as well as pathophysiology and interventions for different types of respiratory disease. So where we don't have, or the lecturers didn't provide learning objectives, I've written some. for you to help direct your understanding of those lectures specifically. So Daniel Steinfurt, he did set the stage for the next few weeks, and what he did was he introduced you to two major diseases of the pulmonary system, and that is asthma and COPD. And he talked to you about the symptoms, the burden of disease. So the burden of disease is going to be important, especially if you're in health professions, to be able to understand what the impact of these diseases are on the community and more broadly. And he talked about the burden of disease, but also the pathophysiology, and that's going to be important. What are the causes? What effect does it have in terms of physiology that manifests then as a disease, which then displays as symptoms? And he introduced you, or went through that system, both for asthma and COPD. And he talked to you about some treatments. So one of the things that connected your practical experience with Dan's lecture is this, and also in Christine Keenan's lecture, was how we determine whether an individual has asthma or COPD in the clinic. And that was by using, for example, airway hyperresponsiveness tests to look at reversible bronchoconstriction in the face of an allergen, or using methacholine. And so he introduced you to how in the clinic clinicians actually discriminate between asthma and COPD. And you'll recognise those measurements because we took those measurements when we were doing the prac class, and you've just been immersed in them for the last few weeks with your assignment as well. So he also talked about the clinical implication and the epidemiology. But also, what he really wanted you to be able to do was to understand the rationale for interventions, rationale for drug use, for example, for these diseases and their therapeutic application. And what I should say is that we don't expect you to remember all of the drugs that were mentioned. We'd like you to be able to recognise important drug classes, though, so you'll be able to talk about them without necessarily providing a specific example of a drug within that class. And that's because we need you to know the drug classes, because you're going to need to be able to put them in the context of their rationale for use. So Gary Anderson gave you two lectures where he really drilled into more detail into COPD. And so you'll see some overlap here because he's asked you to describe the pathophysiological features of COPD, and I wrote these, I've indicated where that's the case. And so there is some overlap with the first lecture, but that's good, it's reinforcement. And Gary wanted you to really be able to understand the causes of COPD. So the causes being environmental exposure, such as smoking, and also the biomass burning, and also air pollution. And from there, be able to recognise that these exposures induce an inflammatory response, and the mechanism through, you should be able to describe the mechanism through which lung damage is induced. So creation of, for example, with smoking, creation of oxidative stress, you get a series of inflammatory events. Then that leads to increase in mucus production, fibrosis of the airways, but you also get a destruction of the parenchyma, which means the lung no longer functions. The parenchyma is the functional part of the tissue, so the alveolar units, and then you get a destruction of connective tissue, which then manifests as what we observe in COPD. So one of the other things, actually I'll come back to that. So Gary also talked about why COPD is of global concern. So it's not just about smoking. We've got an increase in air pollution, and we've also got third world countries who are also increasing their rates of smoking, which you will have heard from Nathan Grills as well. So Gary also went beyond that mechanism to start to talk about the importance of the cholinergic nerves that innervate the lung, and how it's starting to, there's more of a focus on this important role of acetylcholine in perpetuating this pathophysiology. And this is because it not only has a role in bronchoconstriction, but also because this upregulation of production of acetylcholine, particularly by these nerves that innervate the distal airways actually perpetuates this mucus production, perpetuates the airway remodelling, perpetuates the fibrosis as well. And that became really important when he started to talk about the future for drug therapies and what are being used. So Gary introduced you in more detail to therapeutic treatments such as bronchodilators, use of steroids, vaccinations as well, he briefly touched upon, and then introduce you to if we reflect back on this importance of acetylcholine in perpetuating the pathophysiological symptoms seen in COPD, that there is some difficulty in developing muscarinic receptor antagonists. So the idea being that you make an antagonist which is going to bind to that muscarinic receptor to block it and to stop the release of, or the response to acetylcholine, thereby minimising those damaging effects. And the difficulty with that was because of the similarity in structure between the different subtypes of muscarinic receptors. So this really led into also when should interventions occur. So Christine also talked about this, which is that there's been very little success in developing treatments for individuals with COPD and particularly emphysema. And one of the problems is that you start to see events which can occur up to tens of years prior to the clinical diagnosis of COPD or emphysema. And so that when you actually start to use interventions, there's no tissue left to respond. So it's very difficult to be able to get maintain the physiological function of the lung or to improve it because you've had such massive destruction of the lung connective tissue and parenchyma. So the idea was that he started to think, and the field has started to think about whether we need to start intervening early, need to start intervening when we're seeing that chronic inflammation. And so he mentioned approaches of using some of these anti-inflammatory agents or these anti-muscarinic agents muscarinic receptor agents to be able to start to prevent the progression of the disease at a much earlier rate. He talked about one of the indicating factors was chest x-rays and lower respiratory tract infections and how they start to increase and there's a correlation between these lower respiratory tract infections and outcomes for COPD. So I hope that's a bit of a summary and it pulls it together for you. So the idea really is for COPD to start treating that inflammation early. So Nathan Grills, and I've gone in chronological order of the lectures. So Nathan Grills is a fantastic individual who travels a lot, works in a lot of third world countries, and he introduced you to public policy approaches that can be used to minimise the harm of tobacco use. And so he introduced you to, once again, the scale of the problem. And the scale of the problem is, I remember last year someone said to me, I don't even know why we're studying smoking anymore because nobody smokes. And it's true that in Australia smoking rates have really decreased. It's been the most successful public policy or campaign to minimise harm and to improve the health of individuals by encouraging cessation of smoking or preventing the taking up of smoking. But it is becoming a huge burden and having a huge impact in third world countries. So it's not just us, it's a global concern. And so then he talked about changes to policy and how they've occurred over 30 to 40 years and how effective those interventions have been and how Australia's been a real world leader in particularly plain packaging, but also in their campaigns to take on the tobacco industry, which is a huge multinational, international conglomerate that has a lot of power in government. So he talked about what works: taxation, banning advertising, marketing techniques, education, and also regulation of accessibility as well. And so I would hope that you'd be able to see how it's a combination of those factors that actually have had an influence. And it hasn't been one intervention, it's been a sustained influence, which I think is in contrast to what Robin Room was talking about, of the difficulties in being able to change legislation around alcohol use. So this really relates to his final point, which is what can we learn from tobacco control for application to other public health campaigns as well. And you should be aware that there are still barriers that exist in being able to implement these. So then we moved from COPD to explore another common respiratory disease, which is asthma. So Christine has asked you to be able to understand the pathobiology and clinical manifestations of asthma. So what are the symptoms? How's it measured? What's the pathobiology? So the causes, whether they be host, which are rare, or environmental, and the pathophysiology causes symptoms of mucus hypersecretion, you get airway hyperresponsiveness, and you get an increase in airway remodelling with an increase in smooth muscle, which becomes very responsive to particular allergens. So clinical manifestations, the symptoms, I'm sure you know them by now. And connecting back to Dan Steinfurt's lecture about how we measure this, and so Christine showed you a really lovely example of dose-dependent airway responsiveness between normal individuals and those with asthma to methacholine, for example. So she then talked about the mechanism of action of current anti-asthma agents, and they were really in three broad categories, which is the use of relievers, so short-acting beta agonists, the use of controllers, long-acting beta agonists, and also preventers, which is using steroids to suppress that increased level of inflammation within the lung. And so their rationale, and so you should be able to explain why they're used and how they're used. And then she introduced you to the idea of, well, I've covered the drug combinations of why you can't just use, for example, a short-acting beta agonist. You need to have long-term maintenance and control, so prevention, control and relief. And then she talked about future drug development strategies. So future drug development strategies, so she talked about how there are different types of asthma, and she talked about different approaches for the management of, for instance, steroid-resistant asthma. And so a couple of the future directions were the use of bronchial thermoplasty. So this discussion that also cropped up in Gary's talk, which was about what is the importance of smooth muscle in the airways. And this idea that as a treatment for asthma, if steroids aren't working and you're getting a lot of exacerbations, that you can remove these cells in order to prevent the hyperresponsiveness. And it's shown some success in a small sample size. The other was the development of interleukin-8 receptor or CXCR2 inhibitors for non-TH2 steroid-resistant type asthma as well. So I'd hope that you'd be able to recognise the value of that in your discussions. So Christine extended upon that, but focused her discussion of the use of biologicals for respiratory disease. And so particularly these were the use of antibodies as biological therapies, and they include anti-IgE antibodies, so omalizumab, anti-IL-5 antibodies, and then also dupilumab, which actually blocks IL-4 and IL-13 and has shown quite significant success. So she talked about what biological therapies are and the advantages of them and how they've been modified and improved in order to minimise recognition all the way to fully humanised antibodies. The mechanism of action, so how they actually block the binding of the, for example, interleukin to its receptor, and thereby stopping downstream events to perpetuate the inflammatory response. So the mechanism of action of those, and then to appreciate the potential of gene editing for therapeutics. And the example she provided here was the use of really new gene editing techniques and technologies like CRISPR for correcting the defective CFTR receptor in cystic fibrosis. And I know you've heard a lot about cystic fibrosis in first semester. So then yours truly spoke to you about respiratory stem cells. So this was a carry-on from our second block, and I introduced you to these ideas of what stem cells we have in the adult lung and what we know about them, and approaches that have been used in terms of stem cells to be able to try and have a cellular-based therapy for lung disease. And really, I just showed you that we have such diversity in the pathophysiology of different lung diseases, and there's such a huge range of different cell types within the lung that it's quite a challenge. And there have been approaches using decellularisation to maintain a three-dimensional topography of the lung, but there are difficulties in getting the 40 to 60 different cell types that are required in the correct locations. And there's been some advances in decellularisation of tracheal implants, which has been more successful because it's a less complex tissue. So then we talked a little bit about stem cell therapies that are currently in use in clinical trials, and they included mesenchymal stromal cells. And this is because they seem to, although they don't contribute or engraft into the tissue, they have these immunomodulatory effects. And so there are multiple clinical trials underway, either using bone marrow-derived mesenchymal stromal cells or MSCs derived from iPS cells as well. And they're still at an early stage. So we then moved on to Mike McDonough's video, which was posted on Tuesday, and I thought this was a really terrific lecture. And this was a new addition. The reason we included this was because we weren't really talking about why smoking was difficult to stop and why it's challenging to be able to get people to cease smoking cigarettes. And so Mike brought you from his perspective as a practicing clinician and expert in addictive substances that quitting smoking is really hard, and that's because of the nature of nicotine. It's positively rewarding, so it provides reward, and that's what gives its basis to its addictive effects, is because you're actually able to deliver a bolus-like dose of nicotine directly to the brain, which stimulates the release of dopamine, and you get this positive reward of sensation, and that becomes highly addictive. And so it's not necessarily about, although Mike said it's actually not always pharmacological interventions that help people stop smoking, it is a willpower. It is very difficult, and I thought that was a really important message to try and get across in this block of lectures. So what were the barriers to successful quitting? And Mike talked about some of those, whether they be social or physiological. And the different interventions. So not just about intervening, but intervening at the appropriate time where the individual who's thinking about it is going to be most responsive to that. So then Mike started to talk about pharmacological ways of being able to assist individuals to break the habit. And the main one that he discussed was nicotine replacement therapy. And he emphasised the importance of combined therapy in maintaining a stable plasma nicotine, but also having a second delivery system of either gum or a spray to mimic those effects of having those peak levels as you would when you were smoking a cigarette. Although Mike provided you with lots of different drugs, I don't expect you to remember all of them, but just identify what some of those key ones would be. So nicotine replacement therapy is important. Varenicline he talked about, which was Champix, and that was this nicotine receptor partial agonist. So what it does is it binds to the nicotine receptor and it induces a partial agonist effect, so there's some release of dopamine, but it also blocks that receptor from having a more potent agonist binding, thereby minimising the effect of when you start to smoke a cigarette and have that nicotine being delivered, it doesn't have its effect as much. So the other ones I just wanted to identify were cytosine, which although it hasn't been proven, and I should emphasise that these first-line treatments have very strong clinical data to support their use. Cytosine, which is a third-line pharmacological agent, although it's not as effective, it's cheap. And because it's cheap, then it has applications to countries where it's very difficult or out of people's affordability to be able to buy nicotine replacement patches and gum and spray or Champix. So, and the final one that he alerted you to were e-cigarettes and how there's controversy around the use of e-cigarettes. On one hand, some individuals think that you're just delivering nicotine and therefore you're reducing all of the harmful additional chemicals that are part of the burning of tobacco. But there are questions about the constituents of within that e-cigarette that are part of the nicotine delivery system. And also this idea about marketing as well, where you actually advertising is starting to change to make e-cigarettes seem like a safe alternative and attractive, putting nice fruity flavours in them to attract a new wave of individuals, young people who are easily influenced, starting up a habit. And then lastly, he talked about cannabis smoking, and this will relate again to the pain and drug dependence block, about the relative levels of THC and cannabidiol within within cannabis, and this proportion is different for medicinal cannabis, which you'll hear about. But that cannabis smoking is associated with, also often mixed with tobacco, and so you have this double-edged sword, or this double problem where you've got individuals smoking cannabis. But it's also mixed with tobacco, which makes it hard to give up because of the addictive effects of nicotine in the tobacco. Okay, these are Mike's summary slides, which I won't go through because I've just talked about them. So when you approach this block, but not just this block, when you approach revising the metabolic syndrome block, revising the stem cell block, and pulling together the pain and drug dependence block when you get to that, I found this flowchart really helpful in identifying what are the key things that you should be able to discuss. Because this subject is a big picture subject, we're holistically asking you to be able to pull together a problem from multiple different avenues. What's the problem? And it's questions that you should be thinking about. How common is it? This is this burden. How serious is it? Does it affect other people? Alcohol use affects other people, not just the individual who consumes the alcohol. What are the associated factors? How do they produce? So this is the mechanism of pathophysiology, for example. Can something be done? Who should do it? What should be done? When should it be done? Will it work? And will the problem be altered? And then you finish this iterative loop. And I think you'll notice that for most of the lecturers, most of these blocks actually have this theme running through them, and I think that you're going to find it very helpful to take that approach. Terry showed you Bloom's taxonomy. I think the coloration is appropriate considering the university's release on support of same-sex marriage. Remember, I said science and politics always mix. And this was really to get you to start thinking about the different levels of your learning. And so one of our recommendations is to take each lecture or form a study group to start off with. Don't do this on your own because it's not as fun, not as enjoyable. But take each lecture and write possible exam questions within that lecture. If you start to think about the questions that we might ask you, you're actually in a much better place than just trying to remember 50 slides from a lecture. And think about increasing complexity of the question, so listing facts all the way through to being able to integrate multiple concepts. And one of the things we'll do in the final week and the week before you'll be preparing is we're going to get you to start putting together some mind maps. And this is where, like that problem-solving iterative loop that I showed you, we're going to get you to start pulling the topics together. You can draw connections between them as a study plan to be able to start making connections between lectures and across blocks as well. And then finally, once you've pulled it all together, look at all the lectures in the block and write some possible exam questions that connect. If you want, I'm more than happy to be posting student questions so that we could have a discussion board where you could post questions for each other, or we can use Peerwise to do it if you want to. But that can be a really good way of focusing your study. So for the next 15 minutes or so, I'd like to introduce you to peer assessment. These quite naff images I got from the internet, because self-assessment and peer assessment is being used more and more, and for good reason. And so I'm going to talk you through why we're going to get you to do that. So as I said, this is going to be the final component of your continuing assessment, and it relates to your major assignment that you've just submitted. So peer assessment is where you are responsible for assessing the work of your fellow classmates. So if we think about Bloom's rainbow taxonomy, peer assessment actually sits pretty close to the top, just under being creative. But it means you actually have to understand something, you have to be able to evaluate the work of someone else's and be able to recognise aspects that are terrific or could be improved. So you actually have to know more than just doing it, and I think you'll recognise this when you do it. So I've done peer assessment in my own graduate studies, and there's a lot of educational research supporting its merits as well. So you might be thinking, why do we want you to do peer assessment? Well, it's going to develop a whole lot of these skills that we've been talking about, these graduate skills. And peer assessment does things like it advances your critical thinking. You have to critically analyse the work of someone else. And that's, when I say critical analysis, not putting it down and being mean about it, not being critical in that sense, but you're actually evaluating the quality of it. It makes you think a bit harder. You have to analyse, you have to clarify your own understanding, you often have to go back to it. And it is something that's critical for lifelong learning. And you have to think, you have to understand, and you'll probably reflect on your own work. Well, I hope that you do. And this is something that we do all the time. So whether you want to have a career in research or you want to be a health professional, if you never do science again, you will be doing peer assessment in some form of your work, either often or all the time, and we do it all the time. What are some examples in biomedical research and in the medical professions? If we want to conduct research, we have to apply for money, and we have to apply for money through the ARC or the NHMRC, and we have to write a grant, and that grant is peer reviewed by our expert peers within our field. So they look at the quality of work and decide whether it's going to be funded or not. So that's whether you have a job or not. Fellowship applications, so if you want money to do your work individually as opposed to a grant, that goes through peer review. If I want to go to a conference, I actually have to submit an abstract, or if I want to apply for an award, I have to submit that, and that's peer reviewed by the panel or the organisers of the conference. If you submit a journal for peer review or journal for publication, it goes through a peer review process, you know all about that. In clinical practice, when you're being evaluated as a student, you'll have peer review from your teachers but also from your peers of your written, oral and technical skills as a clinician. When you're working clinically, often you'll do case reviews, where you'll actually have your work and your interventions, your diagnosis and your interventions evaluated by people that you work with. And I should say, it's not an antagonistic process in many of these. It's actually a really positive process. Even when I'm writing assignments for you or writing lectures, I go through this peer review process with my colleagues to put our ideas together, to get them to analyse what I'm doing, to offer suggestions sometimes, which is then this iterative loop of review. And for most of you, once you're employed, you'll go through a yearly performance appraisal. And we do that here as well. So every year I have my peers and my supervisors evaluate how successful I'm being in what I do. And that's common to many workplaces. So I hope I've emphasised enough to you how relevant it is. And so, as I said, you're going to do this for your major assessment task. We asked you to submit a PDF, and we asked you to submit a de-identified document. It doesn't have your name on it anywhere, and the file's de-identified. The naming of the file is just your student number. This is to make sure the process is anonymous. So by the middle of next week, you're actually going to receive an email, and that email to your student email address is going to have a range of files with it. It's going to have 5 of your peers' files, and it's going to have your own submission as well. Your own submission is for your self-assessment, and the 5 peers is for the peer assessment. And you'll receive those, and you'll be given instructions for completion. There are a couple of other things that you need to access. We've got a report generator, which is how you submit your marks, and then we can collate them. And you'll also be provided with a marking guide, which is going to be available on LMS as well. So my idea or my suggestion for this process is to read the marking guide a couple of times, get a really good idea of what you're looking for. Then read the assignments. I usually go back and read the marking guide again, and then I start marking. So it's not the first time I've read them when I actually come to mark. Once you finish marking your peers' assignments, you actually then go and objectively, I wrote subjectively in the notes, I'm sorry, that was wrong. It should be objectively evaluate your own work. Then you enter your marks very, very carefully into the report generator file and double check for entry errors and for typos. Save your file, and then you submit that via LMS. The hardest part is getting started and feeling comfortable about being equitable. But once you've started, it's quite an enjoyable process. And the fact is, you get to see 5 of your peers' work. So this is the report generator. So this is a little piece of software that you download off LMS. We've got a Mac version and a Windows version. Yours is going to look slightly different to this. It will just open in a window, but you can see that you have to put your student number in here at the top, and then you put your peers' student numbers here, and you're going to have questions 1 through to 10. And then you're going to enter your mark, which will be out of 10 for each question, so it's a total of 100 in the end. You don't have to add them up. And then you save that file. It will save as a text file. And then we can process it. So what will you receive? So after you finish your peer assessment, Michael, Lou and I go through a process where we collate the thousands of marks that have been generated, and we actually present that to you in graphical form. And so you'll actually receive an email that has a graph of your 5 peers' marks and your self-mark as well. And it looks something like this. So you can see here we've got different colours, and the colours indicate your different markers. We've got this thick yellow line. That's your self-assessment for comparison. And one of the things that we do, and I'll talk about this in Making It Fair, is that Michael and I actually look through every student's marks. We go through and we have a look. And what you'll notice here is that there's actually, it's quite consistent. If you have a look at whether the quality of the marks ranging from 7, I think, here all the way up to 10, there's a lot of consistency in the marks. What you'll see, though, is this blue line is completely different for this one question to all of the others. And we can look at that and say, that's clearly a typo. So instead of that being a 10, they've entered a 0 instead. But what we do in this process is we take the 5 marks and we actually take the median of those 5 marks for each question. That means that if we were to take the mean, this typo, this 0, would influence that mark and bring it down. But because we use the median, the middle, it doesn't influence it. So there's robustness in the way that we do this to allow for huge variations in some students' marks. So the overall for mark that you'll get will be the sum of the medians for each question. You can see here this student rated themselves at 87% for this assignment and they got 83% from their peers. So they're a pretty good judge of the quality of their work. Okay, so as I said, this process will be anonymous. The marking guide that you'll receive will be prescriptive, so it'll be detailed. It's going to have a range of trigger questions for you to think about when you evaluate the work of the individual. But it's not going to be too prescriptive that doesn't allow you to be able to use your own interpretation. So these questions are not going, this marking guide will not tell you the right answer. But what it will do is it will have a sequence of questions that will allow you to be able to really objectively be able to determine the quality of that work. And that's the purpose. If we gave you the answers and you were just marking off, here are 10 points that are required, there's no academic judgment in that, which means that you don't learn anything from it. So it makes it harder, but you actually get a lot more out of it. So let's talk about fairness. We review the marks for each student, as I said, graphically to look for anomalies. But we also review the marks given by each student. So this means that if someone gives another student all 10s, we see this very quickly. And if you don't demonstrate to us that you have undertaken this task with consideration and taking a quality approach to it, you'll get an email from us to talk about it. But we actually find, although we've got that most students do this exercise really, really well. They show great judgment. There's consistency and there's quality and reproducibility in the way that they mark. So we look at given, marks received. You'll also have your assignment marked by a tutor who's going to be the expert marker. And so the expert marker will receive exactly the same marking guide as you. So they're on the same page. They don't have more information or less information. They'll have the same. And then, as we do for every assessment, we take the tutor's marks and I compare across the 12 different tutors and we look at their averages and then we adjust, if required, to make sure that each tutor has a similar average. And that means you don't have students overly advantaged or disadvantaged. So we moderate the process. So that makes it fair as well. Okay, you might be thinking, how do I know that the students are going to be marked in a similar way or have the similar academic judgment to an academic? Well, we've done a test for it. So early on, when we were rolling out peer assessment for this subject, Michael Liu gave me, I think it was 30 or 50 assignments blindly. He got a full range from fairly low performing assignment to a fantastic assignment and that full spread, and I didn't know what mark they'd received and I marked them blind. And so what we did is we did a comparison between the student marks and the expert marks, and you can see here that there's a really strong relationship and consistent relationship between the peer mark and the expert mark. What's the difference? Experts are a bit harsher at the lower end. So students are generally more generous to one another when things aren't as good. So when the quality is a bit lower, you're more generous and I'm mean and horrible. But this is very reliable and we're very confident. If we have a look at the R-squared to have a look at the fit, really, of between the student and the peer marks, we've got an R-squared of 0.77. You actually don't even get this strong a relationship between two academics marking pieces of work. So it is very reliable. Okay, so as I said, your final mark is going to be 7.5% is determined by the sum of the median of your peers' marks. 7.5% is determined by your tutor. So you're actually going to have a self-assessment mark, a peer assessment mark, and an expert assessment mark. And they have equal contribution. Your self-assessment doesn't contribute to your mark, I'm sorry. But you'll actually find it's a really good test to see how you're faring. Once you've completed the peer assessment process and we've looked through the marks that you've provided and we think that you've done a good job, and as I said, my students do a really great job, you'll get your 5%. So it's money for jam, really. We're going to provide you with some support. So as I said, you'll get the marking guide. I encourage you to do this together in your study groups if you want to. But we will have a drop-in session, which will be the first week after the mid-semester break. It'll be during your tutorial times. I'll let you know where that's going to be on LMS. It'll probably be in a central location so you can come and visit me or Terry and ask your questions, rather than me going to tutorial classes because that takes a long time. So we'll have a central location. I'll let you know on LMS. And you can ask us specific questions if you're finding it hard to discriminate, for example. And this needs to be done, your peer assessment, by Wednesday, October the 11th, and we'll have your results out to you before the end of semester. So thanks again for coming today, and have a great mid-semester break. Try and have some rest, do something nice. Where Terry and I have been in our marking caves, marking your MSTs. They're with us. There's a lot to mark, a lot to read, but we should have your results out to you by next week. And remember that first lecture back is going to be a review of the MST. All right, thanks a lot.